11.
Tahun dah, 2 tahun.
2 tahun, sama lah.
Sama.
I'm Dr. Anita from Hospital Putrajaya. I'm a hospital breast and endocrine surgeon. Thank you for the kind introduction by the chairperson. And thank you, Ms. Raya, who headed the committee of this update for inviting me to give this talk. Sorry for I couldn't make it as a first speaker. It was quite a horrible journey, about 60 kilometers from Putrajaya to Selayang Hospital. Okay, so the topic that I was given was surveillance and follow-up breast cancer, and it is actually when I went through the whole thing, and when we compare the management of breast cancer when it comes to surveillance and follow-up, it is much more than just looking at the local recurrence, what we call this, doing a follow-up, doing a mammogram, some kind of all those imaging, but it is much more than that. Okay, and it was even updated in the SQ 2015, where they have this survivorship care plan for breast cancer survivors. So my outline of presentation will be, as an introduction, long-term care and survivorship for breast cancer patients, surveillance and follow-up, and conclusion. There will be more that I can explain. So as an introduction, as you know that breast cancer, when we are managing cases, when we are managing this treatment, it's basically it's a cancer care continuum. So when the patient comes for the first time with us and she's been diagnosed as having a breast cancer, then she will be with us forever. Okay, from the beginning, detection and diagnosis, to the treatment of the breast cancer per se, and to manage her survivorship and optimal care for an individual patient differs along the continuum, or even it differs between individual patients. So, as we know that breast cancer is the most common non-cutaneous malignancy among women. It's all over the world, and 4 in 10 female cancer survivors was reported in the USA, and the long-term survival is common after breast cancer treatment now. It is longer. We are having more patients with longer survival rate, with a 5-year survival rate of almost 90%. This is because, as you know, the improvement in terms of management of breast cancer from the detection and diagnosis, screening, up to the surgical treatment and so forth. Okay, and we need to address the survivors' unique post-treatment needs. Once they have completed their treatment, be it surgery or oncological treatment, then we need to follow them up. Okay, and most of them will be lifelong with us. So when we discuss about survivorship, there are a few points that we need to look into. So we have aspects of long-term care and survivorship. First is surveillance of breast cancer recurrence, whether we do it, whether it's a post-mastectomy or post-BCS, breast conserving surgery. And it involves as well screening for second primary. Second primary means whether it's a contralateral tumor, post-mastectomy, or even post-BCS, or second primary following those adjuvant therapy, be be it whether chemo, radiotherapy, or even hormonal therapy. Thirdly is assessment and management of physical and psychosocial long-term effects of treatment. And fourth is maximizing overall health and quality of life. So we will discuss about surveillance for recurrence, what we are looking for, what we mean by recurrence are local or regional recurrence, distance recurrence, assessment of risk of cancer recurrence. We have to look into it, into that matter, and cancer recurrence and second cancers. Interventions to further reduce this risk of cancer and early detection of recurrence and second cancers. So why do we do surveillance for our breast cancer patients? Because they are all at risk of having a second breast cancers. Okay, be it whether local recurrence or contralateral breast cancer, as I mentioned earlier. And these will be associated with increased rates of distant metastasis and breast cancer mortality. And the aim of surveillance is actually to detect recurrence or second breast cancer before symptoms develop. It is something like screening, and then we will allow them to have a better treatment, early treatment, and improve their survival and quality of life. Okay, when we discuss about surveillance, it will involve, if we go through the ESCO guideline or even NCCN, or even the European guideline, the most important surveillance that involves is history and physical examination. We can never run away from this. Okay, this is very basic. And second is history and physical examination means examining, seeing the patient in our medical clinic, in the clinic by the medical personnel. And second is screening the breast for local recurrence or new primary breast cancer, which will involve, the most common tool is mammogram, or in fact just now I think the CEDM might be used for this as well. And usually mammogram we will do it yearly. MRI is not so recommended as routine, but as it will increase risk of false positive findings, and usually it is restricted to, for a high-risk women. And besides imaging, they do discuss on lab tests and other form of imaging, but usually we don't advise or we don't recommend lab tests or other imaging if patient is asymptomatic. Those lab tests basically can be tumor markers, CA3.3, and CEA, and the rest of tumor markers. But it was shown that it doesn't help in terms of even diagnosing and in an asymptomatic patient. Okay, chest X-ray and advanced body imaging, for example, MRI and tomosynthesis, those other form of imaging, it is only performed if we suspect disease recurrence by doing history and clinical examination. So it is not recommended as a routine tool for detecting recurrence. And the other important point is to educate and counsel patients on signs of symptoms of recurrence. I think that is the basic that we need to explain to the patient. So the form of imaging that we use, I think everyone knows about this. What we are looking for is recurrence in the breast or even in the chest wall, in the nodes, or even any spread to the other organ. So the common imaging that we use, as I mentioned earlier, mammogram, and now some of the centers are using, mostly in private, digital breast tomography, or even now HKL. Yeah, I don't very selective. Okay, all right. And we can even use ultrasound and MRI. And as for just now, as I mentioned earlier, other form of imaging, as mentioned earlier by the first speaker, contrast enhanced mammography. The other thing is positron emission mammography, gamma imaging to include molecular breast imaging or breast-specific gamma imaging. These are all mentioned in the literature, but it is not proven to be good for recurrence detection. There is insufficient evidence. Oh, sorry. Put up the slides now. Okay. So this is the just some summary of. Oh, I put up. Yeah. A surveillance and follow-up guideline. If we to compare ESCO 2013 and NCCN 2017. And the first point is to mention, they mention is history and physical examination. How frequent that you need to do is about, for ESCO 2013, this was mentioned earlier, but they have this 2015 version. 3 to 6 monthly for 3 years, and subsequently for the 4th and 5th year, 6 to 12 monthly or annually, and for the subsequent years onwards, the 6th year and so on, is only for annual examination, depending on the individual patient. Okay, if we compare to NCCN, it's not so much different. There's not so much difference. It's a bit simpler. 6 months for 5 years, and then annually. For mammogram, following a BCS, 1 year, it's either you do it 1 year after the initial mammogram prior to the surgery, or 6 months later after the patient has completed their radiotherapy treatment. Okay, and for the subsequent years, it's just for they suggested annually mammogram for the subsequent years, for the 2nd, for the 3rd year, and so on. And for NCCN, they suggested it's something like ESCO, annually mammogram. But as for NCCN and ESCO, they, as I mentioned earlier, they don't recommend blood and any other form of imaging if they are asymptomatic. These are not recommended. Okay, this is our own Malaysian CPG 2nd edition, which was launched in 2010. What we recommended is regular follow-up should be scheduled as listed below. 3 monthly for the first year, then 6 monthly for the next 5 years, and then if the patients are well, so it's just adequate to do an annual follow-up for them. Okay, but this is grade C recommendation, and annual mammography should be offered to all patients with early breast cancer who has undergone treatment to detect recurrence or contralateral new breast cancer. Okay. So just now was looking at how do we do surveillance for recurrence, and besides doing those imaging and examination, as I mentioned earlier, assessing risk of second cancers is important too. And how do we approach it? We must know and we must detect those, even though sporadic breast cancer is much more common compared to the family clusters and hereditary type of breast cancer. But in our current technology, our current situation and management, the risk evaluation and genetic counseling and genetic testing, genetic counseling is coming up. It's like something that we need to look into, alright? And so when we do risk evaluation and genetic counseling, we need to assess patients' cancer family history, and that would be by identifying women who have high risk of a second breast cancer or genetic susceptibility to cancer that may affect other family members. Meaning, if they have other kind of cancers, not necessarily breast cancers, so that would be some form of risk for the patient to develop second cancers besides having breast cancer. And those genetic counseling and testing we need to do for genetic mutation, and for patients with family history of breast or ovarian cancer, or with cancer in a certain age of group, usually for younger patients. Okay, and our genetic testing, as you know, that we have BRCA1 and BRCA2 genetic testing, but unfortunately it is not freely available, widely available in Malaysia. And it should be those genetic risk evaluation and genetic counseling should be recommended in a patient with at least one grandparent of Ashkenazi Jewish, and maybe this is not so much for our population, and which is younger than 50 years of age at diagnosis, or a history of ovarian cancer at any age, or in any first degree or second degree relative. So too many O's, but that's the criteria. And the other criteria is first degree relative with breast cancer diagnosed before the age of 50, or otherwise 2 or more first or second degree relative with breast cancer at any age. And the list goes for bilateral breast cancer in a single patient, or the patient is a male breast cancer patient, and a patient with triple negative breast cancer at 60 years or below. So we consider 60 years as young. Okay? Alright. And so those patients with this higher risk of predisposition to breast cancer, they should be evaluated and tested. And it must be preceded by consultation of genetic counselor. So if we can't just simply send patient for genetic counseling and evaluation, because there's so many things that need to be considered, need to be explained by our genetic counselor before we get them to be tested. There's so many issues. And maybe I think Prof. Aisha should have quite a number of experience in managing this patient and our genetic counselor as well. And why this is important is to formulate a prevention strategy to reduce the risk, as I mentioned earlier. So, okay, that is about genetic testing. And the other evaluation that we need to do for our breast cancer survivors is assessing risk of second cancers. These second cancers are they come up after their adjuvant treatment as per radiation therapy. Example, in developing lung cancer, especially in higher risk for post-mastectomy patient, and it was recorded that increased risk is first seen about 10 years later after completing your treatment, and it's getting higher and higher over time. So, and definitely when the patient is smoking, so that would increase the risk as well. Sarcoma and leukemia plus myelodysplastic syndrome were reported before, but the risk is low. Alright? And secondly is for chemotherapy treatment, they are predisposing patient to leukemia and myelodysplastic syndrome. And hormonal treatment, for example, tamoxifen or even aromatase inhibitors, even though they lowers the risk of second breast cancer, but they increase the risk of uterine cancer and uterine sarcoma, even though the risk is low as well. But we need to look into this matter. Okay, and we always advise patients to look for symptoms of like postmenopausal bleeding or irregular bleeding. Okay, and the other assessment and management of physical and psychosocial long-term effects of treatment. So this associated with several factors. When we approach this patient, we need to know what type of treatment that patient has undergone. Some undergo all of those 3 treatments, chemo, radiation and hormonal, but some may not go through all. And we must know the duration and dose of treatment, because increasing cumulative dose and for example for anthracycline-based chemotherapy drugs and duration of therapy increase the potential risk of developing those long-term side effects. And we need to know the specific type of chemotherapy, as I mentioned earlier, and then the type of hormonal therapy, aromatase inhibitor, or the most common is tamoxifen, and anti-estrogen therapy. And we must know the age of patient during treatment. Alright? And furthermore, even in fact surgery may cause a lot of problem to the patient when it involves body image issues and limited range of movement. For example, when you go and perform an axillary clearance and radiation therapy to the breast or chest wall or regional node, they get skin sensitivity, pain or lymphedema. This is a major issue, lymphedema. But not so much now, maybe because we are doing more of sentinel node biopsy. It was proven that sentinel node biopsy reduced the risk of developing lymphedema compared to axillary clearance. And as for chemotherapy, there are many other complications of those treatments, but I just mentioned a few. Fatigue, sexual dysfunction, hormonal therapy, for example, tamoxifen, so you are inducing some menopausal symptom in the patient. Even molecular targeted therapy, Herceptin, they are known to give risk increment of cardiac dysfunction. So we must make sure patient is free from cardiac disease or no risk factors to develop cardiac dysfunction before we start them with this treatment. And general psychosocial long-term and late effects, for example, stress, depression, relationship problem, right? May cause a major issue to the patient. Okay, this is just side effect on chemotherapy. As you know, the higher the cumulative dose of anthracycline, there is higher risk of developing cardiac event. And chemotherapy will induce, in some patients, menopause in breast cancer patient, and this cardiac disease following breast cancer treatment, the absolute risk of dying from cardiovascular disease is about 1.6 to up to 10.4% following cardiac event after adjuvant treatment. And so more so to an elderly patient, and if they have, and usually it will cause left-sided cardiac dysfunction. So why do they develop all this? Because of coexisting cardiovascular risk factors. Earlier we need to screen them because of radiotherapy, those anthracycline-based chemotherapy, and anti-HER2 therapy. And this cardiotoxicity, when we are monitoring them and when they have gone through anthracycline-based or even Herceptin, we need to what they recommended to monitor lipid profile and provide cardiovascular monitoring. And we must educate the patient. They must know and must be able to identify the signs and symptoms of some those cardiac event. Okay. And when we discuss about chemotherapy inducing menopausal symptoms in breast cancer patient, this ovarian damage is a significant long-term consequence of adjuvant chemotherapy in especially pre-menopausal breast cancer patient. Usually all are affected by resultant menopausal effects. So they will get those menopausal symptoms, and especially when they are young, in their reproductive age, infertility may seriously affect some of the patient. And other side effects, women who retain ovarian function, they possibly will get pregnant during chemotherapy or even post-chemotherapy period. And however, it is there are limited data to show any worse outcome following pregnancy after your chemotherapy. But now they are developing, I think some of centers, they can do this preserving ovarian function in a patient who's going through chemotherapy or radiation therapy. So side effects of endocrine therapy, as I have mentioned earlier, and I think this is the most interesting part when it comes to surveillance and follow-up. I think we always miss this because I think we Malaysian are not so, what do you call this, towards healthy lifestyle, modification, and eating healthy and doing a lot of exercise. But studies has shown that lifestyle modification in breast cancer patients do prolong overall survival. Okay, there are some papers I'm going to mention here. For health promotion, exercise, physical activity and cancer. There's one paper, what they do is, the topic is exercise decreases side effects during treatment, which is fatigue and quality of life outcome of exercise during cancer treatment. So they recruited 52 breast cancer patients and they randomized them to home-based walking program or usual care during chemotherapy or radiation therapy. So these two groups, what they found, women who exercise more than 90 minutes per week. So they divided the time of exercise into 3 or more days, and they reported a significant less fatigue, less emotional distress, higher functional ability, and better quality of life for the patient. Okay? Oh, sorry. And another paper, the topic is exercise and survival after breast cancer diagnosis. This is done among the nurses, published in 2005 in JAMA. There were 2,987 patients, nurses, with early stage of breast cancer. And they categorize them to do low, medium, and high physical activity category. And they found that when they compare the nurses who did only low physical activity, the risk of dying of breast cancer was about 20% less for medium exercise, and at least medium means at least 3 hours per walking at average pace. And the risk of dying is much lower for the high intensity exercise for breast cancer patient. It's up to 40 to 50%. Okay, and they did a study too for whether this exercise will cause more edema to the patient, but they proved that in the 45 breast cancer survivors with axillary clearance, they did randomize them to weight training program or nothing. So what they found is none of the women in the weight training program experienced a noticeable change in arm circumference, which is more than 2 centimeters, and frequency of new lymph edema or worsening or existing lymph edema was similar in both groups. So it doesn't, even if you do exercise, it doesn't worsen the lymph edema condition. Okay. And as for nutrition, body weight in breast cancer patient, we must advise them to maintain good body weight according to your BMI, low-fat diet, high fiber, increased fruits and vegetables, and of course to limit or stop alcohol or smoking. And some studies for the nutritional factor. They did a study by Schlebowski et al. In 2006, Women's Intervention Nutrition Study. They recruited 2,500 patients postmenopausal with early stage breast cancer. And what they do was they randomize this patient within 1 year of surgery to dietary intervention, 8 bi-weekly counseling session by nutritionists versus control, meaning versus nothing, no advice, no monitoring in terms of nutrition. And what they found was at 1 year, those intervention group, they had 1/3 less fat intake per day. And what they found at 5 years, they are reduction about 24% in breast cancer recurrence. And so they conclude that nutrition intervention can decrease recurrence in breast cancer patient. I think of course there will be what we call this, there's a lot more factors that we must see, not just nutrition, when it comes to reduce breast cancer recurrence. Okay, what about body weight and breast cancer? They found that weight gain during adulthood has been found to be consistent and strong predictor of breast cancer risk, whereby overweight women, which BMI is more than 25, they have 1.3 to 2 times more likely to die from breast cancer compared to women with normal weight, normal BMI. So for this, as we have discussed all this, what do we need to do? What strategy that we need to provide for the patient support is basically screening for cancers. That is the most important to prevent as well. And then management of menopausal symptoms, screening for osteoporosis and cardiac risk factors, physical therapy, nutrition, and not to forget psychology and social service. Reconstructive surgery played an important role to improve body image and confidence level for the patient. As I mentioned, genetic counseling, and of course education by newsletter, lectures, personal advice, and medical advice for the patient. So as to conclude, breast cancer survivors face potentially significant impacts on cancer and treatment, and when we follow them up, issue in the patient, basically just to looking for recurrence, just surveillance by imaging and physical examination, but there is a lot more issues that we need to tackle when we handle our breast cancer.